The ATM2 provides certified clinicians with a straightforward and effective integrated passive and active approach to treat musculoskeletal disorders. This presentation discusses the Active Therapeutic Movements Concept, or ATM for short, and how to apply it using the ATM2 clinical device. The ATM concept has three main objectives. Our first goal is to improve a patient's immediate problem. ATM clinicians can expect their suitable patients will leave the clinic significantly better off than when they arrived. Second is fast and effective resolution of the current functional problem and meeting the patient's functional goals. Finally is prevention of the next episode by providing a positive active resolution that promotes patient independence. Think of the ATM clinical reasoning cycle as a compass and steering wheel. It establishes the direction and type of intervention. The cycle starts with the clinician understanding the patient's subjective complaint, which is the reason he or she seeks help. During the functional examination, the clinician will detect movement impairments that are hypothesized as related to the patient's subjective complaint. That is the true north to set your compass by. The prescribed specific active therapeutic movements are then used to steer the patient to normalize the movement impairments. Then the ATMs are reevaluated to assure normalization of those movements. If both the examination and subsequent intervention were successful, the return to normal function and resolution of the patient's subjective complaint closes this cycle. To be effective, the clinician must continuously ensure the treatment is relevant and on the right track. If you're not on track, simply repeat the previous stage of the cycle, taking the new information into account as you move forward again. Let's spend some time discussing movement impairments. It is clear that this patient has a lumbar flexion movement impairment. Her muscles are not firing correctly, so her joint system is compensating and she's in pain.
So just stand and bend forward. Tell me when it gets worse, when the pain gets worse. Where's the pain? Okay, and bend backwards. Yeah, where's it so? Okay.
After a few ATM repetitions, she's not in pain. Her muscular system seems to be firing correctly, which eliminates the need for joints to compensate. The difference in the joint behavior is evident when both clips are paused at end range flexion. Notice the difference in the knee joints, the hip, the lumbar spine, the thoracic spine, and even the cervical spine. After the intervention, the overall range of flexion motion was significantly improved. On the way up from full flexion, the different activation strategies between the two situations is evident. With impaired movement, the return to standing is difficult and painful. After the intervention, the return is easy and pain-free. To achieve such a marked difference in one session, the ATM intervention had to simultaneously address the passive, active, and neural components of the disorder. What steps do you take to normalize a patient's movement? The first step, the setup, changes the impaired movement to become asymptomatic. This is done by repositioning a specific body region and then holding it in that position. Pre-evaluation is the second step taken to ensure the setup success. The patient is taken through a single full range of movement towards the previously impaired movement, while the patient is passively held in the new position on the ATM2 unit. If the movement has indeed turned asymptomatic, the third step, the active therapeutic movements or ATMs, may be initiated. If not, the clinician must return to the setup stage. ATMs are resisted neuromuscular training in the neutral range toward the impaired movement, which is now pain-free due to the successful passive setup. The setup's purpose is to reposition and hold a body region in a new position that will change the impaired movement to be pain-free. Restraining belts are used to hold the position. Each belt is connected to two tightening ratchets, each on either end. The ratchets allow safe and sensitive incremental adjustments by the clinician or independently by the patient. If both ratchets on either side of the same restraining belt are operated simultaneously, rotational forces in the sagittal plane will occur. If the top restraining belt is pulled, posterior pelvic tilt takes place. If the bottom belt is pulled, anterior pelvic tilt occurs. Tightening only one ratchet causes rotational movement in the transverse plane because of the belt's friction on the body. When two restraining belts are placed around the pelvis, pulling the top left ratchet and the bottom right ratchet at the same time creates torsional forces on the pelvis. The single objective is to find a position that allows previously impaired movements to become pain-free while in this passive holding state. The patient should feel totally pain-free and very comfortable in this new position. Only when the desired position is found and the movement is pain-free can the active component of this intervention be introduced. The pre-evaluation ensures that the passive repositioning and holding did change the movement from painful to pain-free. The patient is asked to perform a single full-range movement and report whether it was painful in any way. If the movement is still symptomatic, the setup stage has to be continued until zero pain exists throughout the full range of the movement. Adjust the belt's height or tightness to achieve a zero pain movement. Good communication between the clinician and the patient is vital at this stage. You need to give your patient a clear understanding of the setup's purpose and their role to accurately report sensations, the most comfortable placement of the belts, and rotational forces applied by the ratchets. Patients should be encouraged to find their own pain-free position as they feel the differences with each adjustment. The pre-evaluation provides the clinician with a unique ability to ensure that the movement will be pain-free, even before performing the active clinical intervention that follows. When a pain-free movement is achieved, the next step is the active component. ATMs consist of neuromuscular training in the new pain-free environment provided by the specific passive holding. The ATMs are performed in the neutral range or close to the midline. In this region, the body relies much less upon joints, ligaments, or other passive components to provide stability, and therefore depends upon the active stabilization components to control that region and govern the movements. Resistance to ATMs is provided by relatively stiff elastic bands that have variable resistance options to accommodate the user's current pulling ability. The elastic resistance also ensures that the short-range movement will remain close to the midline. The ATM concept is not a miracle cure and is not suitable for all patients. So to ensure that the ATM concept is suitable, on the first day of treatment, not more than 10 ATMs should be prescribed. Limiting the number of ATMs also minimizes the effect of possible symptom exacerbation. On patients with severe pain, prescribe ATMs in the direction opposite to the painful movement. As the condition improves, ATMs may be initiated towards the painful movement. This is an example of an ATM intervention on a post-double surgery patient performed by Mr. Bud Ferrante of Carmel Orthopedic and Spine Therapy, Carmel, California. One of this patient's impaired movements was a lumbar forward flexion. In this clip, you can see the movement before the intervention.
And bend forward for me and go as... Okay. And she's limited by pain and tension. And how would you rate that out of...
This patient's pelvis was repositioned with two restraining belts around her pelvis on the ATM1, the previous model of the ATM2. Her pain-free position was found to be a combination of posterior pelvic tilt combined with horizontal pelvic rotation towards her painful side. After a successful pre-evaluation, she performed repetitions of lumbar flexion ATMs, now pain-free because of the passive holding. The movements are in the neutral range and are not close to the previously painful range.
Any pain as you do this?
No.
Again, the significant thing here is that she's able to move against resistance, pain-free. I have to think that the neuromuscular firing pattern is changing here because of the stabilization.
The reevaluation ensures that the ATM intervention had the expected effect on the impaired movement. To view the full 30-minute video of this patient's evaluation and ATM session, please contact Back Project. Every clinical approach should be validated by data collected both in the laboratory and in the clinic. A study conducted by Dublin City University demonstrates how the ATM treatment provided immediate relief to a population of chronic low back pain sufferers. The study measured the immediate effect of a uniform intervention on a group of 8 subjects who served as their own control group. On average, this group had suffered from unimproving back pain for 13 years. Before the ATM intervention, their average level of back pain in a standing position was 5 on a scale of 1 through 9. Immediately after the uniform 8-minute ATM intervention, which consisted of 3 sets of 10 extension ATMs and 3 sets of 10 flexion ATMs, their average pain in the standing position was reduced to level 2. The reduction in standing pain remained clinically significant even 3 days after this single active pain-free intervention. Other significant results showing the ability of this concept to assist in resolving lumbar conditions significantly faster have been reported by Dr. Mark Archambault at the Back to Golf Clinic in Windsor, California. The clinical data demonstrated that incorporating the ATM concept into their performance and fitness physical therapy significantly shortened the amount of treatments needed to resolve an array of lumbar diagnoses. A total of 79 patients receiving ATM treatments as part of their management were compared to patients with similar lumbar diagnoses treated at the clinic before the introduction of this concept. The average number of treatments was more than halved, from 10.7 to 5. To summarize, the first step in the ATM concept is when the clinician identifies the patient's functional problem. The next step is finding movement impairments that are related to the patient's problem, for which specific ATMs to normalize the related movement impairments can be prescribed. Reevaluating then occurs to ensure that treatment regimen indeed improved the patient's functional problem. The ATM treatment is a functional, weight-bearing, integrated, passive-active, pain-free intervention. It consists of a specific passive stabilization that changes an impaired movement to a pain-free movement. ATMs are then performed toward that movement in the new pain-free environment. When using the ATM concept, immediate improvements in levels of pain, range of motion, and quality of movement are the necessary objectives. Otherwise, the ATMs are not indicated. Learning how to use the ATM2 is logical, easy, and straightforward. This concept enables clinicians to continuously monitor their actions in relation to the outcome and encourages them to create a real difference to their patient's suffering. Contact Back Project LLC for the 2-day course information.